Good evening, everyone. Welcome to the channel, the Long Covid Clinic, What You Can Do with me, Dr. Binita Kane, and
myself, Helen Oakleigh, filmmaker, co-host and founding member.
Right. My screen has frozen, and I don't know if it's me or if it's Helen. I'm just going to take Helen off the stage just for a sec. Oh, I'm just going to take Helen off the stage just for a second. Right. I just had some technical issues there. Helen just froze, and I'm not sure if it was her or me. So I'll introduce the session. We've got a really interesting topic tonight. We're going to be talking about hydration, appetite, and blood sugar in POTS. And I will bring our guest on stage in just a moment. But a reminder that we are live and interactive this evening. So please do put your comments in the chat. And for anyone who can't follow the whole session, it will be recorded and immediately available on the YouTube channel for catch up. Helen will be backstage and keeping an eye on the chat, and I'll invite her back on a little bit later on to do the live Q&A with the audience. So without further ado, I'm going to bring our guest on for tonight, who's Dr. Harriet Carroll. Welcome, Harriet. Harriet's a scientist who runs Long Covid Scientific Consultancy and helps patients navigate long COVID, post-vaccine syndrome and other related conditions. She's got a PhD in nutrition and metabolism, which was focused on appetite and glucose regulation, and holds an honorary status at the University of Lund in Sweden, and continues to research hydration physiology, despite some quite significant struggles with post-vaccine syndrome herself. So welcome, Harriet. It's really brilliant to have you on. I know you're not feeling absolutely brilliant tonight, so we will be cognizant of that. Do you want to just start by telling us a little bit about yourself and how you got interested in the work that you're researching?
Yeah, sure. So my PhD was a lot about hydration, blood sugar, and appetite. And during lockdown, I wrote a paper about thirst. And within that, I made some links to the cholinergic system and a little bit of links to SARS-CoV-2. And then I got a job as a COVID scientist in the NHS. And then I got vaccine injured. And a lot of the hydration stuff that I've researched has actually gone wrong in me. So it was kind of a real life experience. And as you say, I'm doing some honorary work at Lund University in Sweden, and that is focused on astronaut hydration physiology. And what a lot of people don't realize is that when astronauts go to space, everything goes wrong, including their hydration physiology. When they come back to Earth, they actually get what is clinically POTS. It's temporary, it's usually temporary, but it is basically POTS, and they get all the same treatments, or they're trying all the same treatments as we get as POTS patients. So there just happened to be a lot of crossover with my PhD, my work, my lived experience.
Yeah, I mean, it's fascinating that you were a scientist who was studying all of this stuff, and then the irony of you then getting vaccine injured and developing all the symptoms can't be lost on you. And we'll maybe come back to that story at some point. But I first came across you. I posted something on Blue Sky, which is where a lot of us who've kind of left Twitter have gone and share scientific information. And I posted something about thirst and this condition, psychogenic polydipsia, which we'll talk about. And it was quite interesting because I had actual doctors who came on and said, so I think I talked about the fact you can get low circulating blood volume in POTS and in ME and in long COVID. And I had doctors come on and say, well, I know we don't really believe that, because how can you have low circulating blood volume if you've not lost any blood from anywhere and you've not lost any fluid and you're not dehydrated? And the evidence base is small, isn't it? It's not, there aren't huge studies that explain this stuff, but I think this is a really, really key part of understanding POTS. And it is quite complex, the science, and I know we're going to do our best to talk about it simply. But could you just give us a very quick 1 minute on what is POTS, and then let's talk about some of the mechanisms that are causing the very disabling symptoms.
Yeah, so I want to start with saying that POTS, long COVID, etc., they're all very heterogeneous diseases. So I just want to be clear that whenever I talk about a mechanism, it might not apply to everyone, it might not apply to somebody all the time. So this is my perspective, which is very biased towards my research interests. But POTS is clinically an abnormal increase heart rate when standing up, basically. Some people get with that blood pressure changes. The lived experience is a lot more than that. It's a whole body illness. It's not just symptoms when you stand up, it is constant symptoms. And for most people, it's usually a problem with the autonomic nervous system. So the part of the nervous system that does all your automatic functions: breathing, sweating, heart rate, blood pressure, digestion, etc. So it can affect everything. There are some other causes of POTS. There's growing interest in venous compression, for example, but the stuff I'm going to talk about is mostly related to the autonomic nervous system and how that regulates your hormones. And then in terms of what actually happens to our blood volume in POTS, there's two main hormones that I'm interested in, and it's not the full picture. One is called aldosterone and one is called vasopressin. In POTS, there's not very much research on this, but based on what we have and based on clinical and lived experience, in POTS, what we often see is something called renin, which goes along a chain to eventually stimulate aldosterone. That's either normal or low in POTS. And then along that pathway to get to aldosterone, there's something called angiotensin 2. And that's paradoxically high in POTS. It should be low if renin isn't there to stimulate it, but it's paradoxically high. And then the next stage along from angiotensin 2 is aldosterone. Now, if angiotensin 2 is high, we would expect high aldosterone. But what we actually see is low aldosterone. So there's kind of lots of contradictory things going on, and it's not really clear why that's happening. There are some ideas.
These are really key hormones in regulation of water and how much we reabsorb from the kidneys and how much salt we absorb into the system, right?
Yeah, exactly. So aldosterone is your salt storing hormone. So when it's high, you'll pee out less salt. So that salt stays in your body, boosts your blood volume. So you can imagine if that's low, you're just peeing out all the extra salt and your blood volume will get depleted through that mechanism. And then the other hormone I mentioned was vasopressin, and that's your water storage hormone. So when that's high, you pee less, so the water stays in your blood, maintains your blood volume. And vasopressin as well, it's not just a water storage hormone, but it's also a stress hormone. So it's part of something called the HPA axis, which is where cortisol comes from. And vasopressin is along the chain to make cortisol. So what's notable in long COVID and ME in particular is that we quite often see low cortisol, and maybe for some patients, part of that is because their hydration physiology is skewed. They've got low vasopressin, not storing water, got a low stimulation of stress, so that they're not able to produce the cortisol as effectively. So the other kind of how that might link together is if your aldosterone is low, maybe because you're not getting the right signals from your autonomic nervous system. So your aldosterone is low, you store less salt, your blood volume depletes a little bit, and it doesn't stimulate vasopressin because vasopressin is stimulated by the amount of salt in your blood, so the concentration of your blood. So if you're depleting the concentration in your blood, you pee out more water because the vasopressin is not getting stimulated. So in my case, and again, this isn't true for everyone, I had undetectable renin, undetectable aldosterone, low vasopressin compared to before my vaccine injury, and low cortisol. And when I started taking salt, I've now got a stimulus for vasopressin. So I started taking salt, my vasopressin increased, and my cortisol increased. Now, I can't prove that that was definitely the causal chain of events, but mechanistically it does kind of make sense.
Yeah, so one of the main treatments, you know, the non-medical treatments for POTS is drinking lots of fluid and supplementing your diet with lots of salt. And then there is you know, no very clear guidance on how much salt is the right amount of salt, but you know, we generally say between 6 and 10 grams. And then, you know, there's obviously debate amongst people within the POTS community as well about, is that right, and what sort of salt, etc. But it's really interesting that you've given us that kind of overview of the hormones to go, well, this is why, this is, you know, even if people don't really understand all of those links, needless to say, there's feedback loops, isn't there? So if somebody is dehydrated, what should happen is these hormones kick in. You should reabsorb more salt and water, and you should be able to correct your you know, you should be able to be in this kind of nice level of hydration, and it all goes ski whiff in POTS, basically, doesn't it?
Yeah, absolutely. And again, this is why water alone, you know, we're going to talk about thirst, but this low blood volume can stimulate thirst, and water alone won't be sufficient, because drinking water, even just the taste of water, can start to reduce your vasopressin. So you drink more water, it suppresses vasopressin even more, and now you've got less hormone to stop you peeing, so you end up peeing more and more. And what's I find kind of strange in POTS is that a lot of patients will get their blood sodium, or another measure called osmolality, which is a fancy word for concentration. So they'll get normal blood sodium levels and they'll have normal osmolality, and doctors will go, you're fine. But if you think about it, you're peeing out extra salt and you're losing extra water. So the relative concentration is pretty much the same. So you don't really get these big changes because it's all happening together.
Yeah, and it's really difficult to prove because we don't have the right tests available. Most people, you know, can't access any tests that would be useful to them. Like, what tests would be useful if you could put your, you know, get your hands on them? We've already talked about measuring hormone levels.
Yeah, so I would measure renin, aldosterone. They are clinically available in most hospitals in the UK, to my knowledge. Vasopressin, when you get vasopressin measured, you'd want to measure actually something called copeptin, which is a surrogate marker of vasopressin. Vasopressin is really hard to measure, so we use copeptin. That's much less available. So I got mine measured through my colleagues, my research colleagues, but it's really hard to get that measured. I also like looking at 24-hour urine sodium. And when people do this, what I think they should also be doing is taking a very detailed and accurate log of their sodium intake and the form of sodium. Mostly it will be NaCl table salt, but if you're getting any other types of sodium, write that down because it will change the results. And then actually compare your intake to your output. So I don't think just knowing your output is particularly helpful. So in my case, my 24-hour urine sodium had undetectable levels of sodium in. And to our mind, we were like, well, clearly your aldosterone's high and you're trying to store all that sodium, so you're not peeing it out. Whereas actually, my aldosterone was low, my salt intake is naturally very low, and I was just almost in a whole body state of sodium depletion, I reckon. And it was very strange because sodium has a lot of roles in the body, and some symptoms that you wouldn't think of that are related to blood volume and salt actually improved just by taking salt. So for example, my walking speed improved, my myoclonic jerks improved, and my cognitive function improved just from replacing that salt that I was just chronically leaching.
Yeah, and there's so we can sort of move on to thirst, because this is a really interesting topic, again, very under-researched, and you're probably, I don't know how many thirst researchers there are around the world, but you're one of them. And I think this is very interesting, because I have some patients who are so thirsty and they drink liters of water, and then they go and see a doctor, and they get what they used to get diagnosed as psychogenic polydipsia, which is basically a very rare psychiatric condition. And when you and it's Patrick Usher's fantastic work where I've learned this from, but you look at the history of where that came from, it was just, it's just based on someone going, we don't know why it's happened, really. These women, because it affects women more, must be mad, and so let's label it as this. And they've all gone mad and they're drinking too much. And in rare cases, it can be fatal, because you can drink yourself to death if you drink too much water. But we know there's a lot more to it than that, and then it's shifted now. They don't call it psychogenic polydipsia anymore, they call it primary polydipsia, which is essentially the same thing. They go, well, we don't know what it is, people are just drinking too much, and people get this label and they don't get any help. And it's Patrick Usher's brilliant work, as I've said, where he actually figured all this out for himself, and he started taking salt, and it fixed the problem. So can you talk to us about that? Because I have got a number of patients who fall into this category and they don't get any help at all from anyone.
Yeah, so thirst, I think if you go to a doctor with saying, I'm really thirsty, I'm drinking a lot, it's viewed as a very soft symptom. They're just kind of like, why are you telling me this? Until it gets to the point where it's dangerous, and they go, oh, hysteria, obviously. But that doesn't add up to what we know about how we regulate our body water. And there is experiments in the 1800s, in the early 1800s, so 200 years ago, where they gave IV saline to people who were really thirsty, and their thirst disappeared. So 200 years ago we knew this, and now we've kind of regressed and gone, oh no, it's just people being hysterical again. And when it comes to more generally excessive drinking, like you say, it's a potentially fatal behavior. Over drinking, if you consciously try and overdrink it, it physically repulses the brain, and you get anti-swallowing signals, which are a literal effort to overcome. And this effect can come for some people at just adding 500 or 600 milliliters a day to their normal intake. So it's actually quite a low threshold before this kicks in. So in my mind, if you're involuntarily drinking more, something isn't right, because that is virtually unheard of in animals outside of lab conditions, except cows. Cows can weirdly drink too much. Like you say, it is extremely complicated, and I'm meant to be a thirst expert, but I doubt I even understand 10% of what's actually happening. So I'll talk you through a few different options of what can go wrong, but I'm not claiming that's the definitive list of everything. So as you mentioned, as we kind of discussed already, when you increase your blood sodium, that should trigger thirst, and it's literally the most reliable psychological phenomenon that I've ever seen. It's a straight line. If you infuse salt into someone, they'll get progressively more thirsty. And I think the thirst world has got a little bit fixated on that because it's so reliable. And we know it can't be the main mechanism for thirst, because I just took a sip of water, and it's not because all of a sudden my blood osmolality is increased. But when we have this potentially low blood salt in some POTS patients, and low blood volume probably in more blood POTS patients, we don't get that vasopressin trigger to store water, so we're constantly peeing. The water alone is going to further dilute the blood, so we get even lower vasopressin, and then it creates a cycle of drinking more and peeing more. But I suspect some patients, more than what's registered, actually have something called diabetes insipidus, and that's nothing to do with blood sugar. This is a water storage problem. Now, this is a really important reason why I don't think we should be ignoring thirst, because there are different forms of diabetes insipidus, and the two main flavors are one, an actual reduced ability to produce vasopressin. So you actually just don't have the vasopressin. And if you've got that type of diabetes insipidus, then you need to take desmopressin, and that will replace the vasopressin, and that's a common treatment in POTS as well. But another type of diabetes insipidus is a reduced sensitivity to vasopressin. So vasopressin's there, you're able to produce it, but your body doesn't respond to it. Now, if you've got that particular flavour of diabetes insipidus, the treatment can include a low salt and low protein diet to reduce urine production. So now you imagine you're a POTS patient, you go to your doctor, you've got POTS, you're really thirsty, and they go, well, the POTS guidelines say, have loads of salt, drink loads of water, but your body doesn't respond to vasopressin. If they looked at those guidelines, they'd say, actually, the having a lot of salt thing needs to be rethought in this particular context. And then some patients, like Patrick, have done diabetes insipidus testing, which involves water restriction, and they find that their thirst goes away, which sounds counterintuitive. When you stop drinking, you should get thirsty, but it does make sense. This is called dipsogenic diabetes insipidus. It makes sense because you've stopped drinking, so now your blood has finally got a chance to concentrate, and that then stimulates vasopressin and boosts your blood volume, so you get this reduced thirst signal. So that's kind of the least controversial mechanism for thirst in POTS.
So, and I think you'd expect that endocrine clinics would be all over this and understand this stuff and be able to diagnose these kind of things. But in my experience, and I never want to disparage any other colleagues, but in my experience, the endocrinologists that my patients go and see tend to just go, everything's fine, you've got psychogenic polydipsia, off you go, rather than doing some of these tests, unless they've got a particular special interest in vasopressin or diabetes insipidus. A little bit like many cardiologists aren't trained in how to manage POTS. It's not really a heart condition, it's a nervous system condition. So it puts patients in a very difficult position. So what would be the ideal workup in your view for someone who's very thirsty, drinking excessive amounts of fluid? Are there tests that you think are available on the NHS that we should be able to access? Or is it a case of just trialing some salt and doing some water deprivation and trying to sort it out yourself? It's a really hard question. I apologize for that.
I mean, in the real world, I would, if you genuinely have excessive thirst and excessive drinking, I do think you should get tested for diabetes insipidus. In a realistic world where I know that you have to find a unicorn doctor to even consider that, you can try more salt. But again, it's just difficult to really say that with any confidence, because if you have the type of diabetes insipidus where lower salt is more helpful, and you've got POTS at the same time, you really do need someone who's engaged to put those pieces of the puzzle together and to get the most efficacious treatment plan in place for you with the fewest risks that actually makes sense for your particular physiology. So yeah, it's actually one of the hardest parts of my work, is that I can speak to patients and give them all the ideas in the world, and they then go to their doctor and the doctor's like, nah, I don't know what you're talking about.
It's really hard. It's really difficult. But I have got one patient that's just sprung to mind who just can't tolerate the salt. So she's definitely got bad POTS. And I've done the usual, take your 6 to 10 grams a day, and just I always recommend people increase it slowly. She's like, can't tolerate more than 2 grams. And this explanation you've given this evening kind of makes sense, because I was like, that's I'll have to chat to Harriet about this, because that doesn't make too much sense to me. But yeah, that's really good to know, because there is definitely that group of patients who don't tolerate the salt. Does it mean that they can't get their POTS under control though if they can't tolerate the salt? I mean, this is the difficult thing, isn't it?
Yeah, I guess it would depend on the type of POTS, and there are ways around, things. So some patients are going to be in a difficult position, unfortunately, but for others, you might be able to find ways around. For example, just in my experience, and I'm not saying this is universal, but kind of on average, I've heard a lot more from hyperpot patients, so those who get an increase in blood pressure when they stand up. They seem to respond less well or not at all to salt. And it might just be because blood volume isn't their biggest problem. And you can focus on other aspects. And again, that's why checking, is your aldosterone, is your vasopressin actually functioning properly, can actually help direct. If your aldosterone is fine or it's high, you don't need to give fludrocortisone, because fludrocortisone mimics aldosterone. So you're actually then going to run the risk of suppressing the body's own natural production of aldosterone. So you could be causing a longer term harm just because you haven't run a blood test. So again, it's really difficult because getting doctors to do that, and there are restrictions. Some people I know get very frustrated at their GP. Realistically, GPs can't even run all these tests. So it's kind of like working, you have to try and work the system that you're in, and also, unfortunately, self-experiment safely. But that's kind of a bit of an oxymoron to say, because if you don't know what you're dealing with, how can you self-experiment safely? So
yeah, but that's the position a lot of people find themselves in. And sadly, if we had massive studies on all of this stuff with thousands of patients and guidelines, and there was new treatments being developed, it'd be very different. But we're still at the stage where we're kind of talking about the real basic scientific research. So I'm going to move on a little bit, because, like I told you, this goes very, very fast once we start chatting. About POTS and blood sugar, because I've got patients who definitely, they describe symptoms where they get shaky and it mimics hypoglycemia. You're like, well, that just sounds exactly like somebody having a hypoglycemic attack. Some of them will go and buy the blood glucose monitoring, the Freestyle Libres and things, and check the blood sugar, and the blood sugars will be absolutely in the normal range. And other patients will get this very severe sort of what we call hyperphagia, which is excessive hunger. And I've got a few that have, put on a lot of weight because they've developed this excessive hunger. So, and there's not much when you look into the world of research around blood sugar and POTS. So can you shed any light on those symptoms?
Yeah, well, no guarantees. These are some thoughts. I guess I'll start with glucose regulation, very complex, but broadly, it's a fight between insulin and glucagon. So insulin takes sugar out of your blood, gets it into cells. There are other ways to get sugar into cells without insulin, but that's insulin's primary job. And then glucagon, which tells the liver to produce more glucose. Now, in healthy people, it doesn't matter how much you eat, how much you exercise, how much you fast, blood sugar will stay within this range because you're healthy and everything functions. And I think what's also interesting to note is that there is one study I'm aware of that looked at these hypoglycemic episodes in otherwise healthy women, and 95% of the time, their CGM showed normal glycemia.
So that's the blood sugar monitoring, the CGM.
Yeah, the CGM, sorry. So this phenomenon of low blood sugar isn't unique to POTS. Other people do experience it. Now, when it comes to measuring blood sugar, we use the CGM, the continuous glucose monitors, or the finger prick. And without going into it too much, basically, there are a lot of limitations to these. So the numbers aren't always the true numbers. So there's a possibility that you simply have missed hypoglycemia because of measurement error. There's some other kind of logistical possibilities, and it could be things like it's a general POTS or dysautonomia episode that's just presenting in a different way than what you're used to for whatever reason. It might just be that our autonomic nervous system is oversensitive. So when you're getting normal blood sugar, it's actually detecting that as low blood sugar, and we don't, for some reason, just because your autonomic nervous system is a bit skewy. So there might be some practical reasons for these events that do actually indicate low blood sugar, or your body registers low blood sugar. But the thing that I wanted to talk about, most excited to talk to you about, is insulin. And neurons are insulin, they're not insulin dependent, but they're insulin responsive. And insulin can actually help metabolic dysfunction at nerves and diabetes. It can help re-innervation, and it can even improve diabetic neuropathy pain. And we all kind of think of insulin, you probably know it's produced in the pancreas, right? But actually, insulin's also produced in the brain. And in rat brains, in some regions, there is 100 times higher levels of insulin than in their blood. And that suggests insulin is really important. And in stressed mice, the hypothalamus actually produces less insulin, and this restricts growth due to its effects on the pituitary gland. Now, if you think about POTS, it's a constant state of stress. So do we kind of get similar, where we've got less insulin production in the brain, it's affecting the pituitary, and then we get low thyroid, ACTH problems, which stimulates cortisol, so we get low cortisol, and we get sex hormone dysfunction. That all kind of leads me on to this main possibility that I think might be happening. And it's called neuroglycopenia. And this is low sugar in the nervous system. Now, this typically occurs with low blood sugar, but it doesn't have to. And things that can trigger neuroglycopenia are infections, autoimmune diseases, sepsis, cortisol deficiency. And that sounds very similar to ME, POTS, MCAS, traumatic brain injury. Now, the symptoms of pure neuroglycopenia are stroke-like symptoms, headaches, cognitive problems, seizures, dizziness, and fainting. What does that sound like? Kind of a bit like POTS. Now, if you've got low sugar in the cerebrospinal fluid, the CSF, it's a condition, I'm going to butcher this, but it's a condition called hypoglycocorrhachia. And again, this can be caused by infections, encephalitis, autoimmune diseases. And the most interesting one is something called a GLUT1 deficiency. Now, GLUT1 is a transporter, and it helps get sugar into the brain. And it is a rare metabolic condition in its purest sense. But there is one animal study I'm aware of in ME, and those animals, those rats, I think they were rats or mice, had reduced GLUT1 levels. So they're actually getting reduced transport of glucose to the brain. And usually when we get low glucose to the brain, we'll get increased blood flow to try and stimulate everything. But if we've got POTS and we've got this chronic cerebral hypoperfusion, we might not actually be getting those signals. So it then impairs the counter-regulatory response to try and make more sugar. And there's a part of diabetes called happy hypoglycemia, where they just don't really register the hypoglycemia. And I do wonder, in chronic illness, are we in this chronic state of feeling so awful that we've got chronically low sugar in the CNS, and then sometimes we'll get these big episodes, and that presents with these hypoglycemia symptoms?
Yeah, that's really interesting, Harriet. And I know this is kind of still theoretical because the research hasn't been done, but there is clues, as you say, from all of these other studies as to what's going on. I think that idea of this being a central nervous system problem and affecting the pituitary gland, which is related to the cortisol and the very, it's most of my patients, many of them have a low morning cortisol and end up having the test to look at whether they're the glands, the adrenal glands which produce cortisol, are working, and they're usually working. And we know that this is probably more to do with the mechanism of what's controlling that gland from the brain. And so I think this idea that all of these things are linked is really interesting. Wouldn't it be fantastic if we could give you millions of pounds to research this stuff? That would be really, really great.
I accept.
Yeah, that's what we need. We need people like you who can start researching this. But I've also had a couple of patients who've had the high hunger signals who have gone on to be diagnosed with insulin resistance. So they can produce insulin, which should drive sugar down and put sugar back into cells, but actually the cells become resistant to the insulin, and that is the mechanism, and that can respond to treatments like metformin, for example. So there's also that mechanism as well, isn't there?
Yeah, I really want to emphasize that insulin, I think insulin gets a really bad rap. People think of insulin as a bad thing, but insulin resistance is the bad thing. When we respond to insulin, it's actually really helpful for a lot of things. It's actually anti-neuroinflammatory. So it's intranasal insulin is actually being researched for Alzheimer's. And I do wonder if it could be helpful for some long COVID patients, just because it's anti-neuroinflammatory, and it will also help stimulate getting glucose into the nervous system more effectively and help the metabolic side of things as well. So yeah, I think there's some good work that could be done there, and it links, you mentioned this hunger, it links perfectly to hyperphagia, hunger, excess eating, and like thirst, I think hunger, if you go to the doctor and say I'm really hungry all the time, it'd be like, go away, you're wasting my time. It's viewed as another soft symptom. But if you think about how hunger actually works, you get this sensory input, so taste, smell, swallowing, you take the food in, you get this peripheral response, your hormones respond, and that information gets sent to the vagus nerve, which then goes to the brain, especially the hypothalamus, and that creates an appetite response. Now, you can already tell if we've got dysautonomia, our vagus nerve isn't working properly, so we're already probably getting some skewy signals. And I guess, I think I'll write a blog on some of the biology of hunger in this a little bit more detail. But I guess I want to talk about insulin and mast cells. Just, I think we've got enough time for me to go on a little rant about these. So insulin is actually, a lot of people say insulin makes you hungry, but it's the reverse. Insulin is a satiety hormone in and of itself, but it's also a hormone that triggers the release of lots of other satiety hormones like GLP-1, which we've heard a lot of recently. So it's insulin resistance that's the problem. So if you're insulin resistant, you lose the trigger to satiety, and if you're getting central nervous system insulin resistance, you might not see that in a blood test because it's going to be compartmentalized to the CNS. And you're also going to lose that anti-inflammatory response. And inflammation in the brain might actually be the cause of some of the appetite response that we're getting. So I'm just trying to pick which bit I want to talk about. So we'll talk about mast cells because it's inflammation. So again, not huge amounts of work on this, but I want to talk about a model of obesity in animals. So again, whether this translates to humans, not 100% sure. But I want to talk about a particular study in obese animals because it shows how mast cells can be involved in appetite dysregulation. And regardless of body mass, I think similar could be happening in MCAS, which a lot of patients have, and dysautonomia, because the autonomic nervous system regulates the mast cells. So basically, in obesity, we don't tend to actually grow new fat cells. What happens predominantly is the fat cells we have get bigger. And as they get bigger, they get more insulin resistant, they get more inflammatory, and they get more mast cells around them. So it's a huge inflammatory milieu that's happening. And obesity in itself is also a neuroinflammatory disease. There's neuroinflammation going on, which is possibly contributing to the appetite signal issues. Now, in the brain, inflammation is regulated by special immune cells called microglia, and mast cells activate microglia. And when you, in the appetite regulating areas of the brain in mice, there are increased mast cells and increased microglia. And when they then inject cromolyn into the brain of these animals, their body mass reduces, the fat cell size reduces, energy intake reduces, they get improved glucose regulation, and they get improvements in the neurons that regulate appetite.
And cromolyn targets mast cells, just to make that clear.
Yes. Yeah. And I guess it's also a good point that when we take oral cromolyn, it doesn't get absorbed, so that stays in the gut. So you can't take cromolyn and expect it to act directly in the brain. Yeah. But it gives us a hint.
Watching, they might have heard of it as sodium chromoglycate, which is the tablets that some people with MCAS are on, but that just tends to work in the gut at gut level, but doesn't get into the central nervous system.
So they were literally injecting it straight into the brain, so it would have actions where it's put. And then they made mice without any mast cells, and again all of these positive changes happen. And then they made mice with less microglia, and when they reduced the microglia, the mast cells no longer cause the appetite problems. So it suggests that mast cells interact with the microglia, cause neuroinflammation, and that causes this appetite dysregulation. And I think in MCAS and POTS and dysautonomia, you can get decreased appetite, increased appetite, or a mixed, confusing signal appetite. And that is exactly what we see quite often in obesity, where they have blunted fullness signals and blunted hunger inhibition signals. So it's this constant state of permanently not quite full, not quite hungry, and lots of food noise. And I think if you think about all the dysregulation that's happening, some of us might be experiencing that kind of thing as well. Yeah. And I've not even touched on 1% of how complex appetite is, but to me, appetite and thirst always comes back to neuroimmune function, and none of that to me sounds like a soft symptom that should be ignored.
Yeah, and I think hopefully this conversation is validating to people who are suffering from these symptoms and have been told, there's nothing wrong with you, you're a bit mad, this is psychogenic, off you go, think yourself better, do some CBT, because there is an awful lot going on. As you say, we've probably scratched 1% of the surface. So just before I bring Helen back on, because we are rapidly running out of time, and I'm conscious of your energy levels as well, I do want to just give you a chance to talk about the service that you have set up, which is the Long Covid Scientific Consultancy work. So you're not a doctor, you can't give medical advice, but just give us a couple of quick headlines about what you do in your service, because I think it's really brilliant.
Thank you. Thanks for that opportunity. Basically, when I fell ill after my vaccine, I was scrambling for answers, and I was messaging one of the people I did my PhD with is an immunologist at Harvard, and I was messaging him like, what's going on, help me, and he didn't have a clue, and I didn't have anyone to turn to, and doctors didn't have a clue, and I just sat there and I was like, I wish I had someone to talk to and who understands this. And that's essentially what my service does. I try and be as impartial as possible. I don't promote any protocols. It's just patients will go, I've got all of these symptoms, what tests should I ask for? And what are the treatment options? What are the pros and cons of all these treatments? And I'm not advocating to take any of those. It's just, I find doctors throw pills at you and go, just take this fludrocortisone. But then they don't know, if you're taking that, there's a black box warning for psychiatric effects. You need to get your electrolytes checked regularly. You can't just take it and stop. It has immune suppressive effects. They don't get any of that explained. And I'm just there to say, here's the information, so you can go ahead and make an informed decision as best as possible. And you've got a point of contact so that if you're not sure about anything, you can say, hey, I don't know what I'm doing, can you help? I guess I don't really know how to sum up my service. It's just something. I think
from what I've seen of, I know some patients who've seen you, you can assimilate large amounts of random information and make sense of it.
Thank you.
It doesn't make sense to many of us, and you can sort of go, oh yeah, well that makes sense because this and this, and think about drug interactions and yes, I think that's how I'd summarize it. But it's really helpful. I think the challenge, as you say, is what do patients do once they've got that info getting the support they need to implement the changes. But I'm going to bring Helen back on, so we have got quite a few questions. Are you doing okay, Harriet, for now?
Yeah, I'm fine. Yeah.
Good. Welcome back, Helen. Sorry about your technical issues earlier and having to whip you off the stage. I don't know if
I don't know if you heard what I said or not, but I think it was all the fireworks. So unfortunate timing, 6 o'clock on the 5th of November. Hopefully it's okay now.
My bad, that's my fault. Right.
Thank you so much, Harriet. It's really, really informative and really useful, and brings together a lot of stuff that, of course, bits are known, bits are kind of, it just makes sense, you know, putting that jigsaw together. There are lots of questions. I will get through as many as I can. Really good question to kick us off then is it best to have tests run while you are not taking supplemental sodium? So that's, I guess, how much does that impact the results?
It really depends on what your aims are. So if you want to know what your baseline is, then yes, come off salt. But if you want to know, you know, is this actually having an impact, or how much salt am I, you know, if I've started to supplement with 9 grams of salt, if I then do a 24-hour urine sodium test and I'm peeing out 12 grams of salt, you need to go, oh, there's still a problem that needs addressing. So it really depends on what your aims are, but to get a good baseline, probably best to come off it. And I'd also caution that your well-being is the most important thing. If coming off salt for 2 or 3 days before tests is really going to mess you up, it's probably not worth it just to get information. Like, you really have to think the impact of what that's going to have on you, as well as the outcome of the test. What does the test result actually mean? What am I going to do with that information?
Can I ask a question on that? So if you came off your salt, you weren't on any, and you had a baseline 24-hour urinary sodium, can you work out how much salt you need from that test? I'm just trying to figure this out.
No, to me, it gives an indication of what your aldosterone is doing. So if you've got urine, if you've got salt in, so the amount of salt you're taking in, and salt out, the amount that you're peeing out, you can see if you're more or less in salt balance, or if you're peeing out more salt than you're taking on, then you've really got a problem, most likely got a problem with aldosterone. So it kind of gives you that kind of clue as to, is this an aldosterone too low problem? Because the flip side is, if you've got low blood volume, the normal response is for aldosterone to increase to try and store salt. So you might find you're having salt and you're not peeing as much out, and that's maybe because aldosterone is really high. So even if you can't get the aldosterone test, which is much less accessible, you might be able to get the 24-hour urine sodium test, which is maybe more accessible. And from that, you can get an indication of your salt balance, and therefore an indication, not definitive, but an indication of your aldosterone function.
Thank you.
In theory at least.
That's really interesting. So say you, for example, if you were nil by mouth, what would that then, is there a general baseline of what that would be?
What do you mean?
I guess, sorry, that's a bit specific, isn't it? Sorry, that's my bad. I was processing and trying to catch up and ask the question at the same time. Classic brain fog. Yeah, not to worry. We'll move on. So Sarah asks, is it worth trying to get a renal referral, or is this another area where we may come across doctors who are yet to catch up with types of dysautonomia? And I guess around that, you know, is there kind of any kind of information that you could take to not even a renal specialist, but even your GP, to say, this information is here, is this useful, or is that patronizing? Is that not the right thing to do? Like, yeah, general advice around that would be useful.
My general impression is that finding the right doctor is more important than finding a particular specialist doctor. Generally, if you think about diabetes insipidus, it's usually an endocrinology doctor who should be seeing you, at least at first. But going to your GP informed with information, generally speaking, I'm seeing a shift towards GPs being more open to receiving information. Again, it will vary between who your doctors are, but it can be helpful and kind of place the onus on them. Like, what are you going to do? Here's some information, here are my symptoms and how they match. What are you going to do about this? And they can make the referral, make a case. But I think there are kind of key words that will more likely get you a referral. Like if you want to see a rheumatologist, you want to emphasize joint pain. You don't want to talk about fatigue and headaches and really vague symptoms. You want to be like, rheumatologists are interested in things like joint pain and connective tissue disorders. So you want to emphasize the things that are going to be relevant to the referral that you want. So if it's diabetes insipidus, it will most likely be endocrinology that you want to see. So,
I think what's really challenging in this case, of course, renal physicians understand renin and aldosterone, but generally doctors don't understand dysautonomia, and I think that's we're just not taught about it. Full stop. We're not taught about things like POTS, and I think that is changing now post 2020. But it's historically, anyone who trained before 2020 is not going to get teaching on ME and POTS and all of these conditions. So there's a massive gap. And I think we have to remember our NHS colleagues are under enormous strain just with the stuff we do have pathways for and the stuff that we should be doing, and they're commissioned to deliver. So this additional stuff where it involves all that headspace and thinking and working stuff out, and there's no pathway, and they'll send you to renal will reject the referral. It's really difficult. So whilst we can sort of say, look, take these things to your doctor, at the same time, there's reasons. Generally, most doctors are trying to do a good job. They don't want to.
Yeah.
Oh, absolutely.
Suffer, but your hands are tied as an NHS doctor in what you can and can't do. So I think it's important to put that side across as well.
Yeah, absolutely. And huge respect for anyone trying to navigate this from a professional point of view as well as a patient point of view. Huge respect. So it's a lot.
So any more questions you
highlight? Shall I?
Yeah, I can pop one up. So Amanda's got ME but doesn't have POTS or diabetes, but she needs to drink a lot of water or feels dehydrated and gets awful migraine like headaches. I think it's just a comment, really. I think it probably feeds into your what you talk about, Harriet, in terms of that thirst doesn't necessarily correlate with body water status, does it?
No, and we didn't get into lots of other stuff that can affect body water regulation, and we do also know in ME that there is evidence of low vasopressin, so it might be a matter of salt, but again, there's a lot of stuff going on there, particularly with migraines and salt can sometimes not interact well. So yeah, there's just a lot going on with ME that crosses over with POTS, that crosses over with low blood volume, which crosses over with a lot of the neuroregulation of water status as well.
I don't know if this sheds more light on it. Also happens to her when when her head's lower than her heart, which is quite interesting. Yeah. Down dog yoga, love that, Amanda. I'm so pleased you're doing the yoga practice. So yeah, it's up to these symptoms that are very real, but people can't explain what's going on. There's something physiological going on there.
So what's happening is there are stretch sensitive ions across the body and lots of barrier receptors that detect essentially your hydration status. And you've got some in your kidneys and some in your brain. Now, when you have POTS and you stand up, part of the issue is that our blood pulls downwards into our thorax and abdomen. And that might then be sending signals to the kidneys saying we're overhydrated, pee more. And at the same time, we're not getting enough blood volume to our brain. So we're kind of getting reduced stretch signaling, which is then sending thirst signals. You're thirsty, you're drinking more, you're peeing more, and then it creates this cycle with vasopressin getting lower and lower. And then when you put your head down, the blood rushes to your brain And this is what happens in space. The blood shunts up to the astronaut's head, and their forehead actually expands, and their legs get really skinny. It's called chicken legs. So all that blood goes up, and that then triggers your brain to detect overhydration. So that then triggers a diuresis signal, and it's one reason why it's generally recommended in POTS to kind of prop yourself up in bed a little bit, not lie flat, and certainly not put your head below your heart, because that's going to be a trigger to diuresis, and then that will trigger all your thirst response again. So basically in POTS, whatever you do, it's wrong. If you lie down, it's wrong. If you stand up, it's wrong. It's always wrong, unfortunately.
Yeah, that sounds about right.
Yeah.
I was going to come on to Rose and also combine with Vivian as well, actually. The two questions there about types of food and how that can impact. So whether that's blood sugar spiking and the impact of that, or if it's carb heavy food as well, and how that impacts, and general thoughts around that, really.
Yeah, so when there is one study in this, and that showed that when POTS patients eat particularly carbohydrates, it increases a hormone called GIP, and this is an incretin hormone, and that means it stimulates insulin. But GIP also increases the amount of blood that goes to your gut. It's called splanchnic vasodilation, so more blood in the abdomen. And now if you think it's getting attracted to the abdomen, that means it's not going to the brain. So you might get compensatory tachycardia from that. And then if you also think about the role of the autonomic nervous system, part of that is just digestion. So you're kind of putting a stressor on an already skewy system to try and digest food, which can probably also contribute to symptoms. And then there is in POTS, based on limited evidence, kind of the early signs of insulin resistance. So when patients eat sugar or carbohydrates, they'll get a normal blood glucose response, but their insulin seems to be higher and it stays higher for longer, which means you're essentially needing much more insulin to try and get the sugar into the cells. So that might, because there's insulin resistance, that in itself might be changing our neurofunction just in and of itself. We're not getting the anti-inflammatory effects, not getting the satiety effects, we're not getting other like metabolic effects in the nerves as well. So it could be related to the dilation, it could be related to the insulin resistance, and I'm sure there are a ton of other things that it could be related to.
Yeah, I remember when my daughter was quite poor, when she was at her worst with her long COVID, she would eat a meal, she'd stop after maybe half of it or a third of it. She'd go as white as a sheet, and then she'd just go, I need to go and lie down. And that was, you know, she had that proper sort of splanchnic dumping of blood. So yeah, it's I'm sure, and lots of patients get that. So, you know, we do recommend small, frequent meals if you're suffering with POTS, not being too carb heavy, and just listening to your body. Really, it's really important to not ignore those symptoms or just normalize them.
Yeah, and I think the flip side, I'll just put this in because I think it's a really nice demonstration of how different we all are. For me, carbohydrates make me feel a lot better. And I don't get any issues eating big meals. I prefer eating big meals. And that's not to say it's wrong to eat the small meals or it's wrong to eat the big meals, but it's, again, just always finding what works for you. I quite often, a lot of the patients I speak to, they go, well, I heard so-and-so say they do this and therefore I'm going to do that. And I think, no, you need to find what works for you, for your illness, but also for your mental health, for your just general comfort, for your enjoyment. You know, you don't, with MCAS in particular, people cut out everything and they'll be like, I've stopped having gluten and sugar and dairy and this and this and this. And they're like, if you don't need to cut them out, don't cut them out, because part of food is enjoyment. So I think it's just really important, you know, if carbs don't affect you in that way and you enjoy eating carbs, I don't want anyone to be sitting there going, well, that's it, I need to eat smaller meals of low carbs from now on. You know, if you don't need to, you don't need to. So I think taking that balance as well.
Yeah, absolutely. And tying
Really
into
great
that, sorry, I
advice.
hope you can hear me with all these fireworks going off. It's like I'm under attack here. And following on from that, with the gastroparesis, so the question as well, does hunger from POTS make a diagnosis of gastroparesis less likely, or can they coexist? I guess, you know, obviously some people, yourself, you prefer bigger meals. For me, it's very much the opposite. I really struggle to eat at all. So I guess with that, how does that interact if you're not, if that's not working as it should be?
I don't know enough about gastroparesis to give an informed answer. So I would say they can coexist. A lot of POTS patients do have gastroparesis. A lot of dysautonomia and ME patients have it. I don't know enough about the physiology of it to give an informed answer. Binita might be able to jump in.
Not really. They can definitely coexist. Of course, I've lots of.
Yeah.
There's a study that was published last year that showed people with POTS have significantly higher and more severe gastric symptoms than people without POTS. And you know, the idea is that the enteric nervous system, which is the gut nervous system, you know, the POTS is almost a surrogate marker of dysfunction in the nervous system in the gut as well. So that was sort of there, but again, it's poorly understood and researched. But we could carry on chatting to Harriet all night, but I'm really conscious of your energy levels, Harriet, and you've already done it over an hour. So I am going to call it there. There's just a couple of comments I wanted to just pop up before we finish. Where's it gone? I'm just desperately scrolling through. One of them basically said, let's do a fundraising campaign for Harriet. I can't find it now, but yeah, I completely agree. If anyone wants to, like, you know, dig deep into their pockets, if you know any billionaires, please do let us know, because it would just be amazing if we could fund this research and have research programs looking at it. And I think the other one, here it is. This is a nice one to finish on. It's actual live feedback for your service, Harriet. So someone who said that she'd highly recommend it from Mia. Thank you, Mia.
Thank you.
So just leaves me to say a massive thank you, Harriet. Appreciate that, you know, that you've put yourself out a lot this evening to chat to us. It's one that I'll probably have to go over and take notes on again and try and get my head around all the physiology. You hope that
I will because we didn't get, you told me this would happen, we didn't get through it, not even half the stuff I'd written, so I'll try and write some blogs and break some of this down a bit more.
Yeah.
And I do have a couple of papers in the back of my mind I want to write, so give me time for that, but I'll try and get some blogs out for everyone.
And once those are ready, we can share those on the channel as well. And thanks very much, Helen, for joining us. And so the next session, I think, is in December. I think it's the 10th. Don't hold me to that. And I'll be interviewing Klaus Wirth, who is doing some amazing work on mitochondria in ME. And that will be another quite heavily scientific session, but very interesting. So I'll just say good night, and I'll see you next time. Thanks very much for joining us, everyone, and for the brilliant interaction in the chat. See you later.
Thank you.
Thank you so much again.